Good afternoon. My name is Mark Baldassare, President and CEO of the Public Policy Institute of California. Thank you for joining us today. PPIC is pleased to present this two-part program about the many lessons learned during the pandemic and what the U.S. and California Health and Human Service agencies are doing. In the first half, we have Xavier Becerra, Secretary of the U.S. Department of Health and Human Services. In the second half, we have Dr. Mark Ghaly, Secretary of the California Health and Human Services Agency. Before we start, as a public charity, PPIC does not take or support positions on any ballot measure or legislation, nor does it support, endorse, or oppose any political parties or candidates for public office. Today's event is part of PPIC's 2022 speaker series on California's future. We'd like to thank our sponsors, listed on your screen and on our website. This series is also funded by the PPIC donor and corporate circles. And before we begin, if you have a question for Secretary Becerra or Secretary Ghaly, please send an email to the address on the screen. Please include your name and organization with your question. We will be answering questions as they come in, so please send them. And with that, I would now like to welcome Xavier Becerra, the Secretary of the U.S. Department of Health and Human Services. Secretary Becerra, good afternoon. Thank you so much for taking the time today.
Great to be with you, Mark.
It's a pleasure to see you again. It's been too long since we've had a chance to talk. So my first question, how would you characterize where the U.S. stands right now with regard to COVID? And how likely are we to face another wave this winter?
Well, we're certainly not where we were, which is good, but we're not where we need to be, which means we have work to do. Let's put it this way. When the Biden administration came in, we were losing 3,000, 4,000. At one point, we lost up to 5,000 people a day from COVID. Today, we're losing 300 to 400 people a day. And so far better than we saw before. But if I were to put it this way to you, Mark, and if I were to say a jetliner crashed in America today and everybody on the flight perished, that's essentially 300 or 400 people, but it's going on every day. If we had a jetliner in America crashing every day, killing everyone on board, we'd be talking about how we're going to change our aviation industry or finding out what's going on. And so having 300 or 400 people die a day from COVID means we still have to figure out what we can do to get this under control and get rid of COVID. So far better than we were, still work to do.
Thank you. So how do you see this unfolding this winter as people make plans for travel, for going back to work in January, the holidays, how should we all be thinking about where we are with COVID?
A real celebration if you got vaccinated. A real celebration if you made sure your family members got vaccinated. Anyone you're planning to hug or kiss during these holidays, I hope they and you are vaccinated, because you stand the least chance of becoming ill, severely ill, hospitalized, dying, if you've been vaccinated. I'm not just saying it because I'm Secretary of Health and Human Services. I'm saying it because that's what the facts show. The people who are dying today are principally people who are unvaccinated or haven't gotten an up-to-date vaccine, so their the strength of their immunity has waned. And what we want folks is to be prepared, because the winter months are when viruses typically hit us hardest, whether it's the flu or whether it's the RSV virus that some people are seeing with their children, or whether it's COVID. So get vaxxed, hug and kiss your family.
I'm taking notes on that right now. Thank you. When people hear that that we still have a federal emergency, it sounds alarming to them, and maybe that's what it should be. But what exactly does it mean for us to be in an emergency, and how long do you see that going on?
Yeah, and as I said, if an airline were to crash right now and it would be breaking news while we're speaking, we would say we just lost 300 people in an airline crash. That would be breaking news, because it would be an emergent situation. But if it happened every single day, of course we'd consider it an emergency. We are still in a state of a public health emergency. We are not where we were before.
Mhm.
And we can see the light at the end of the tunnel. And so we won't need to have a public health emergency declared. Until then, though, the authorities that public health emergency declaration provides are crucial to providers who have the ability to flexibly offer telehealth services to people who can't travel easily, so that we can make sure that we're collecting the data to let us understand where we have deficiencies in immunization, in vaccination. And so the public health emergency has been a tremendous asset in helping us deal with this crisis that we have in a pandemic called COVID.
Thank you. So you've been in your position since early 2021. If we reflect on the time that's passed, particularly the time that you've been in office, what observations do you have about the lessons that we've learned for the nation in terms of our public health readiness and response?
Perhaps the most important thing I can try to articulate to folks that has become very obvious as a result of COVID is that we have a nationwide public health system. And if you listen to me closely, I didn't say we have a national public health system that covers the nation. We have a nationwide, which means it's a patchwork of systems that cobble together to form what we consider our national system of public health. The result of having a patchwork is that between the seams, people fall through. And that's where we lose so many Americans, and not just with COVID, but with chronic diseases, with the inability to give people access to preventative care that would keep them healthier. Our health system is broken because it, as advanced and as sophisticated and as good as it is, it's only as good as the stitching that weaves it all together. And COVID proved to us that we have a patchy public health system that is nationwide, not national. That's perhaps the most important thing I learned. The other thing I hope has become clear to everyone is that none of us are safe until all of us are safe. And so when we talk about reaching out to some of our communities that are typically left behind, it's not just important because we should give them access to care. It's because your health depends on them, because they may be in that passenger seat on that plane next to you the next time you fly, and you want to make sure that they have the same level of coverage that you would want for yourself. And so we have to do the things that are smart to keep us all protected. And the final thing I'd say is that I wish we would treat medicine, healthcare, based on the properties that should drive it, the properties of science, not the properties of economics.
Those are very valuable lessons, and they can certainly be applied to a lot of public policy going forward. I'm wondering about the impact of new federal dollars on the U.S. public health infrastructure. I realize that many of the dollars are new dollars and some haven't been spent yet, but you're somebody who spent time in Congress. I'm sure you've followed the legislation very closely and how it's going to impact our public health infrastructure. But how do you see the new dollars being spent impacting the issues that you're describing in terms of the needs of our public health system, and specifically around the race and income gaps that you mentioned?
Mark, without those new dollars, we would not have reached as many people. We would have had more people dying of COVID, and we'd have more people that in their middle of life would end up having chronic diseases that at the end of their life would cost you and I far more money. But because COVID gave us a chance to make the public, the country understand that we could not wait for everyone to have access to care the way it typically happens. We went out there and rushed to give everyone a chance to get vaccinated. No vaccine has cost anyone a penny in America. It cost billions of dollars to manufacture and to invent those vaccines, but it didn't cost Americans a penny out of their particular pocket. We did pay as taxpayers to make it possible for the federal government to incent the innovation, but paying out of pocket to go to the pharmacy or your doctor to get vaccinated, nope, it's free. As a result, a lot of Americans have been vaccinated. But I will tell you this, But for those additional dollars, we wouldn't have had the capacity to do that. But for those additional dollars, I couldn't tell you that today in America, there are more Americans who have access to healthcare through health insurance than ever in the country's history. More than 300 million Americans today have health insurance coverage. That's a record. And guess what? I think this year we're going to beat that record because so far the enrollment rates for Obamacare, the Affordable Care Act marketplace healthcare coverage, is exceeding last year's record pace. And that's all a good sign. And the best sign of that is some of those communities that you mentioned at the end that are typically left out, the Black and Brown community, low-income communities, our LGBTQI plus community, they're getting in. We had record numbers of people enrolled in Obamacare last year, highest number ever. That was principally because we had more than 50% increase in Latino and about 50% increase in Black community representation coming into the marketplace exchanges and getting their coverage. So we want to continue to do that. That's how we were able to erase the disparity in vaccination between Black and Brown communities and the white community. We went to where they were and they responded. And that's what we intend to do again, is go where people are that are in between those stitch parts of our public health system that fall through those cracks. We're going to go to them rather than wait for them to come to us.
Thank you, Secretary. We have a related question, which I want to make sure we get some audience questions from Mark Carlson, who's retired from the Evangelical Lutheran Church in America, who asks, what have we learned from the pandemic about equity and access and meeting the needs of underserved, disadvantaged, and ethnically and racially diverse communities?
So the point I just made at the end, that we can't wait for folks to come to us. We have to go to them. What we found is that there are some people who are working 2 or 3 jobs who don't have the ability to go to a place to get vaccinated if it's not right in front of them. There are some people who never were given time off of work, in fact, could lose their job if they try to take the time to go when the vaccination centers might be available. There were people who were very skeptical. I just did an event within the last week commemorating the 50-year anniversary of the end of the Tuskegee study, which some of you may know. Believe it or not, this country used NIH, our National Institutes of Health, to conduct a study on syphilis. And what we did was we found over 600 Americans and asked them about syphilis. And if they had syphilis, rather than treating them with medication, we allowed them to be guinea pigs to see what would happen to them and see what kind of medication might work or might not work with them. Essentially, we treated them as guinea pigs. The difference here is that of those 600, I think it was 623 or so Americans, all of them were Black men. And we obviously never do that anymore because it's not only unconscionable, it's unethical. And it means lives are lost. And so we need to make sure that people want to participate in our healthcare system. It's tough to get people to want to get vaccinated when you tell them, no, don't worry, it's free. When they say, wait a minute, I know someone in my family's past who was told, participate in this project because it's going to be good for your health, and find out that no, it was actually bad for their health. And so we have to break those barriers. And that means reaching out to folks where we can. And with COVID, that's what we've done. No cost for the vaccine, going where people need us to be. We're going to continue to do that. And that's how we were able to reach parity in vaccination rates with all communities in America. And that's what we're going to continue to do to get more people insured, including Black and Brown communities, low-income communities, who have often been those that have been left behind.
Thank you, Secretary Becerra. You mentioned what you've seen in your travels around the country, and I know that earlier this year you visited communities to learn about the toll that the pandemic has taken on behavioral health and mental health. And I think it would be really valuable for our audience to learn about what you saw and how it's changed your thinking about improving our mental health system.
I've spoken to people who have lost brothers and sisters, sons and daughters as a result of overdose. I have spoken to families who are saying that their children are presenting suicidal thoughts. I have spoken to clinicians who are burnt out, but have to continue forward because there are people who are on the edge. And I've seen how this pandemic has taken our stress levels to the nth degree. And what we need to do is reduce, if not eliminate, I hope, the stigma attached to mental health or to substance use disorder. We have to give people a sense that it makes sense for us to be there to help them get the services that they need to prevent them from either using drugs or from letting the mental health, behavioral health issue take over, or at least making sure they get the treatment. We're doing something different as well in this administration. Our new strategy on drug overdose prevention is to provide harm reduction services as well. So it's not just prevention and treatment, but it's trying to reduce the harm that someone can cause themselves while they are using. At the same time, we're going to beef up that last part, which is recovery support, so that once you've gotten through the treatment and you think you're ready to go, we don't want you to fall simply because you find that there's not enough community support for you going forward. And so we're going to do a number of things differently, but we're going to take the president's lead. He said we should be treating behavioral health, mental health, the same way we treat physical health. There should be no prejudice or discrimination or lack of treatment, equal treatment because of a mental health concern.
Thank you. I appreciate hearing that. You talked about the stress and strain that the pandemic has caused, and some of the people who've experienced that stress and strain are the health workers in our public health system. We hear stories about burnout, people leaving the field early, and obviously the pandemic has put an enormous strain on the people who provide essential services in the system. And I think it would be valuable for everybody to hear about what steps the administration is taking to strengthen the nation's health workforce.
And Mark, there we've done more than has ever been done, but it's still not enough. We, for example, under a fund that was created by Congress called the Provider Relief Fund, provided a lot of hospitals, clinics, service providers with additional help to help cover their costs, excess costs, in providing COVID services in ways that never before had been seen. We have provided direct dollars for institutions to be able to beef up their workforce, whether it means giving them some time off, some of the workforce time off, or giving them additional training, or simply providing them with access to behavioral health services that they might need themselves to get themselves back in order. We would love to do more of that. Congress needs to give us additional dollars, but we're going to continue to offer the assistance that helps. We have beefed up our programs that help recruit people to serve in the medical professions. So, for example, nurses and physicians, we offer a loan forgiveness program for those who go through a nursing or a physician program, and others as well, health allied professions. And where if they work in a underserved community for a certain number of years, the loan that they will have received from us, from the federal government, will be forgiven. And in fact, my son-in-law is going through that process right now. He's a pediatrician, newly minted pediatrician. He's now working in Salinas, California, in a health clinic where he's serving mostly low-income families, and he's providing service back. He got his medical school education paid by the government, and now he's paying back by working in an underserved community for at least 5 years. And so we hope to have more people take us up on that offer. We'll do what we can. But when you have problems like not enough nursing schools or teachers at nursing schools to teach the people who would like to be the nurses to meet the shortage, you got a real problem. And so we have to all work together on that issue. And that's where each state has to pull together with us, because we don't fund those things directly. It's principally through the state governments that you really resource all your health services and supports.
Secretary Becerra, one of the other stresses that Americans are feeling this year is inflation and the rising costs of everything, basically. I wonder if you could talk about the Inflation Reduction Act signed into law by the president, what it means for healthcare, prescription drugs, and this great concern that Americans have about how they're going to afford healthcare that they need.
Yeah, it's a big issue. Fortunately, Congress did pass the Inflation Reduction Act, which for the first time ever removes the handcuffs that I and the federal government had in trying to get the best price for prescription medication for Americans that would be possible. Now, as a result of this law, the Secretary of the Department of Health and Human Services will be able to negotiate to get the best price of medicines for Medicare recipients. Some 65 million Americans receive Medicare. We wanted to do it for the entire country, but Congress couldn't get the votes to make it possible to include everyone. But we at least got it for Medicare recipients. So starting in the next couple of years, we will begin the negotiation, and Americans will begin to see the price of many of those drugs that they need in those very expensive categories come down. We also, for example, have seen a reduction in the price of something very important on the behavioral health side, on drug use, and that is naloxone. We have seen an actual drop in the price of naloxone that helps save lives because we made it easier for prescribers to have the ability to do so without being hounded by law enforcement as if they were trying to prescribe drugs to folks who may have an addiction. And so I think there are things that we're doing in the healthcare space that are actually reducing the price of medicine and healthcare. Medicare recipients this year will see a reduction in the cost of their Medicare premium. That's a biggie for them. And so at least on the healthcare side, I can tell you there's some pretty good news with regard to some of those costs.
Terrific. I'm glad to hear that. I'm wondering what you're expecting out of the lame duck session, or maybe hoping might come out of the lame duck session in terms of your department, and how you're thinking about the leadership change that's occurring in the 118th Congress, not just the party leadership change, but the intra-party change that's taking place.
At the end of the day, COVID doesn't care about who's leading the House or the Senate. People who are suffering from severe mental stress and are considering suicide really don't care who controls the House, who controls the Senate. We just need to provide some assistance and relief. And so one way or the other, our budget is for saving lives. It's not about politics. And I would just urge the members in the House and the Senate, and I congratulate all those who lost, and I wish well those who are moving on, whether through retirement or through loss, but we need to work. We need some COVID dollars to continue to keep America safe and stay ahead of this virus. We need support to keep all those 300 million plus Americans insured. We need to continue to make progress in behavioral health so everyone knows that whether it's your broken bone that's getting mended or your flu or whether it is your depression, you're going to have access to the healthcare that you need. And so that's my call to Congress. Don't treat us like a political widget. We're healthcare that everyone in America needs, whether you're red or blue.
Well, you were a member of Congress, and so you know what that world is like as well as the one that you're in now. I'm told by your staff that there's time for only one more question. So I'm going to ask the question that came from a physician in Southern California. It's a big question. What is your vision for the U.S. health system in the 21st century? And how can California help to achieve that vision?
So we have the brightest minds. You know, we helped them invent this wonderfully successful vaccine. We have the capacity that most countries around the world envy. And we have this get it done attitude that has been part of American history forever. And so I'd say the glass is only half full when it comes to America and our healthcare. But here's what I would say. We can't be so inefficient. We can't let the dollar drive our healthcare decisions so much. We have to care for people, everyone. And COVID has taught us that even the least among us need to get some care, because if they don't, they can infect the most privileged among us. And so I would simply say that we can't have patchwork systems of healthcare. Europe has far higher rates of vaccination than we have in America because they have a system that's far more of an integrated public health system. We need to integrate that. We can't leave people behind. And so at the end of the day, my goal, what I would hope for, wish for America in terms of health in the future, that we be inclusive, that we don't base it on your access based on your zip code,
Mhm.
and that we recognize that everyone would like to be healthy. And if you see someone who isn't, it's not because they don't care. It's oftentimes because they don't know or they don't have access to what they need to be healthy. And so let's talk about wellness, about preventing illness versus remedying or curing it. As my mother would always tell me, mejor prevenir que remediar, better to prevent than to remediate. Or as Frederick Douglass said so well, it is easier to raise strong children than it is to repair broken men.
Mm.
Easy stuff. We can just do it early.
Very important to keep that in mind. Secretary Becerra, we're so fortunate to have you today. I know what a hectic and busy schedule you have every day. And I just want to thank you for your public service in Congress, as the Attorney General here in California, now as our U.S. Secretary of Health and Human Services. I really appreciate all that you've done for the people of California and all that you're doing for the people of the nation every day in the work that you do. And really very much appreciate your time with us today. Thank you.
Thank you, Mark.
Well, I'd like to now welcome our second speaker, Dr. Mark Ghaly, Secretary of California Health and Human Services Agency. And as a reminder, please submit your questions to ppiceventquestions@gmail.com. So, Dr. Ghaly.
Hey, Mark, great to be with you. Thanks for including me. And just let me say what a pleasure it was to hear the Secretary speak and eloquently answer not so simple questions, especially the last one, but I think a lot of important messages in his work. And I too appreciate his leadership and his teams, both at CMS and at the CDC and others, been terrific partners for California throughout, not just the pandemic, but so many other things. So thanks for including me with him in today's conversation.
Well, thanks. And I am really delighted to have a chance to talk with you again. It's last time we spoke was June 11th, 2021 for an event titled Reopening California. And it's good to now have a chance to catch up with you. I noticed the background was the same, much appreciated as it was when we last spoke. We had agreed to a first question, so I'm just going to go ahead and make the most of this short time that we have together today. Governor Newsom has announced plans to end the COVID-19 state of emergency on February 28th. Today's December 1st, so that's coming up pretty soon, in 3 months. What are the most important implications for California?
Well, first thing to say, Mark, is I want to just spend a moment distinguishing the federal declaration from the state.
Please
really,
do.
And Secretary Becerra highlighted some of the key advantages, the financial flexibilities that allow the state's provider systems to provide telehealth, the ability to do some things, especially on the financial side at the state level, at the local level, that we would otherwise lose. The state level declaration, very different. At the beginning, when we first declared the state of emergency, and over the first many months, over 600 provisions fell under that state of emergency. But over the last year and a half, so many of those have been retired already. So today, two of the key provisions that we're in active conversations with our healthcare delivery systems that should matter to Californians, right? What Californians want to know is, if I get sick, if a family member who gets sick, we're going to be able to get the care we need. And don't have bureaucracy get in that way. And we have been innovative. We have used the tools available to us to really transform the system. We heard about telehealth, but how about the use of different staff, more staff coming in more flexible ways? Our healthcare delivery systems have used that ability, that tool, in terrific ways to meet the needs of Californians. We wish we could have done more at certain times, but it certainly has helped. Similarly, space. How do we use our spaces? Sometimes we have areas of healthcare systems that we don't typically use for the delivery of care that we have had to use under COVID. So those two key pieces, I think, are we're in active conversations with our healthcare delivery partners to see how those tools remain available, right? Working with the legislature, working through the administration and those partners so that when we see these natural ebb and flows, whether it's COVID or some other respiratory threat, which we know we're seeing today, that we have those tools available so that everyday Californians know that we're doing what we can to make sure the systems can be responsive to them. So as long as we're working and focusing on those aspects, I think that we are doing the work that we need to make sure that with or without a state of emergency, this healthcare delivery system that is top-notch in California can deliver what we need to keep Californians safe and healthy.
Thank you. So unlike Secretary Becerra, who came into the COVID crisis in early 2021, you were there from day one, because you came in with the new governor beginning of 2019. So and I haven't had a chance to talk to you for a year and a half. So I'd really appreciate hearing about your reflections on the 2-year plus of COVID and what the lessons have been learned for you and the agency in terms of the state's public health readiness and response.
Well, I remember the very first talk I ever gave as a physician. It was back in San Francisco, and it was really titled, "All Healthcare is Local." And I think we see that today. The response, whether it's the federal or state response, is so key, but how it gets effectuated at the local level. And I'm not just talking about counties, I'm talking about communities and blocks across California. And if we deluded ourselves that we could wake up in the throes of a global pandemic and catch up on issues like equity and disadvantage and distrust of a healthcare delivery system, we've been dissuaded against that idea. The need to invest over the long haul in strategies that bring people to the table, that don't just talk about inclusion, but about belonging, that communities drive what matters for them, first and foremost, is key. I mean, today, despite 3 years of, I think, really important work that we've done on equity, talking about trusted messengers, big investments in communicating in communities that, as Secretary Becerra said, are often overlooked, brown and black communities, other communities that have experienced historic disadvantage. We still see today, despite a statewide low rate of bivalent booster uptake, nearly a 22% difference between our most advantaged and our most disadvantaged communities on uptake. And so, that's just a real reminder what I think we always had a sense of. I felt very early, but it keeps coming true, that we need to spend the energy, the time, the investment in the wake of the worst of the COVID years, I hope, to make sure that we don't expect to that this happens because you snap your fingers or you move the dollars to do it. The long road to trust is real, and we have to keep working on it in every way. So that lesson probably would have said it early, but it's punctuated today, even as I look at our daily vaccine numbers and see those persistent trends. The second thing is communication. I probably said it back then, just our ability to communicate in uncertainty. It comes back down to trust. You don't get to communicate with a lot of flexibility when you don't come into it with a lot of trust. And so we have our work to do. And I'm proud of California for recognizing that and spending the energy to figure out how we're going to keep doing it. Investments in the public health delivery system, as the secretary said. I mean, the governor put $300 million a year, not once, but in an ongoing way to support state and local public health. So it's not a fragmented patchwork, but actually, hopefully over time, something that we can stitch together. So I think all of these things are manifestations of lessons but hopefully not just lessons that we think of academic exercises, but where there's a real investment behind it.
And I want to follow up on that because your agency is Health and Human Services. And I would like to hear from you about how you're thinking about the connection between public health, health services, and social services, and maybe differently today after the pandemic than coming into this.
Yeah, well, we have certainly been for a long time thinking about this, and I often tell my team, I sometimes wish we were the Human Services and Health Agency, because human services come first. The work that the Department of Social Services has done is key. I mean, you and your team, Mark, put out an issue brief a few months ago that talked about the primary importance of CalFresh and how important CalFresh was to low-income populations who both have low incomes and unstable incomes, and how throughout the pandemic, some of those extra food supports that came at timely moments really helped stabilize incomes. And when we talk about food as medicine, the lack of food is the worst type of medicine. And so this idea that we have to look at this really as a triangle, and in my view, with the social services on top, pulled together with health and public health, kind of anchoring those other corners, is key. And that's certainly going to drive the way we continue to think about it, the way we think about integration and connecting the dots. And whether it's the issue of food security or housing security, or what we're going to do to make sure the penetration of Obamacare and Medicaid expansion is real, that's going to be our framework. We're going to lead with social determinants. We're going to talk about how, I really liked what the secretary said, that, no one's safe until everyone's safe. That is a true statement in health.
Yeah.
This notion of population health and the social drivers is really key. So moving through the pandemic, wherever we are in this journey, that's certainly going to be the principle that guides the work, not just across the agency level, but certainly across all of the departments and offices I have the privilege of helping team up with.
Thank you. And I'm going to remember that no one's safe until everyone's safe. Put it up on my wall. There's a question from the audience. Physician would like to hear from you also about how you're thinking about the state of the public health system with respect to our local departments. I had a similar question that I was going to ask you about just your view of where are we with the public health infrastructure today, and what's been the impact of the federal dollars and the federal dollars that will be coming in as a result of some recent legislation.
Well, first, I think no one in public health, I should say, most of us in public health are not surprised in the face of the beast that COVID has been about how inadequate the systems are at all levels. And just look, the secretary brought up data and the need to be able to do it at the federal level. We starved of that issue at the beginning too. We had difficulty figuring out how many tests were done, who was positive, who was negative. We had these epic challenges that really underscored the need to invest. And that's why I'll underscore it again, $300 million to build up that infrastructure. Not enough, but certainly a huge head start that brings California into a position to really innovate and come together. We talked a lot about state level public health and then county level or local health jurisdictions, 58 counties, 61 health jurisdictions across the state. But what about some of the regional opportunities, right? COVID, it didn't move. It moved similar to the weather. It didn't obey county lines. It sort of had Southern California, Northern, Central Valley, Bay Area. It really had it followed these patterns. And so how do we start thinking a little bit more regionally about our assets, about our need to plan together and work together? And our formal public health systems are really divided sometimes from the healthcare delivery system, from the emergency response system. We saw that as a mistake. So the work that has been done locally to bring those three entities together has been terrific. I think we'll all benefit from that. So it's a number of things, but I think the place I will end is with the workforce. It would be inappropriate for me not to thank, with the biggest thank you possible, all the public health leaders, people at the front lines, people making the big decisions who have been through a slog for the last, nearly 3 years.
Yeah.
And my admiration and respect for their commitment and ability to work in uncertainty and under pressure is important. And we need more of them. Some are tired out, some are retiring wisely for them and their families, but we need more people. So the investments in public health programs and those public health schools is going to be really important in the future, because who knows when the next threat comes like this. Frankly, probably going to come sooner and in many different forms. And if we're going to be ready, we need the people with the cultural and community competence to deliver on the new tools that we're making available.
Is there anything that the state is doing or can do to improve or increase the numbers of people in the workforce, or encourage people to stay in? We are in everything that the secretary had to say about this, the national level. I was thinking, and California is an expensive place to live. So what can you do at the state level?
Well, I think there's been a number of things, and the workforce investment on healthcare workforce broadly has been pretty tremendous. I appreciated the example of the secretary's son-in-law, the loan repayment opportunities for individuals who are coming into communities often starving for healthcare providers are real. California has its own loan repayment programs. We early on provided loan repayment to both primary care, dental providers, others in California who worked in primarily Medicaid serving clinics. That was before the pandemic. Now, nearly $200 billion later, over 2, maybe 3 budget cycles, we've invested in behavioral health, nursing, public health professionals, physicians, alternative types of staff, community health workers. I mean, all of these different professionals, but it doesn't come soon enough. Like, you want the tree to grow faster, not that we know it's going to take some time, and the cost of living, the ability to afford education, the ability not to just, licensing fees are expensive. So all of these things are areas where we're trying to address. But I believe in my travels across the state that there are not just hundreds, but there's thousands of Californians who are saying, help, let me pick up an oar and help. We care. We know that this is a commitment to our community, so we're willing to do it, but just give us the resources to get it done. So those are investments that I think we're making. There's so much more to do, but I'm proud of the level of investment that the governor and the legislature has really granted in this area.
Thank you. Another question from the audience. What are the agency's plans going forward to encourage Californians to get the COVID booster and the flu vaccine? A winter surge seems imminent. So what should we be telling our family members and friends and neighbors?
Well, this is trickier than it should be. And first, I appreciate the question, because it's not just focused on COVID. I've had the privilege just this week to visit 3 of our state's children's hospitals and to see the tremendous work, the innovative work, the roll up your sleeves 24/7 attitude that these providers are making throughout Southern California. Members of my team visited Northern California facilities to see the same. And it's not just a story about COVID. If you take COVID alone, we've seen a test positivity that's now over 10%. In those first months of COVID, we would have been aghast at that. And today, somehow we accept it as okay.
Yeah.
We see hospitalization numbers going up pretty quickly. But flu, for the first time during this sort of 3-year period, is a real threat, looking like something we've seen last in 2017, 2018, just a lot earlier than we're used to seeing. And then for young people and older Californians, RSV and other respiratory viruses that, frankly, what I'm worried most about isn't one alone, but when people get co-infected with 2 viruses or a virus and a bacteria, and then you get super sick. So when you think about COVID in the context of a whole heck of a lot more threat, then the vaccine becomes a different calculation. And we are talking about it differently today. I'm not surprised when I look at our vaccine rates and administration. If you look at just yesterday, we're nearly 40% higher in the number of vaccines that we've calculated were given in California, boosters, bivalent boosters, than the 7-day average. And so that what that tells me is Californians are starting to get the message. They're starting to see the reality of the threat. They're talking to their friends in healthcare. They're talking to the family member who missed 3 days of work or school because they're sick. And they're saying, wow, this is really kicking my butt. And we can avoid that. And there's other tools. Vaccines are so important. But I don't want to forget the value of using your mask when you're in indoor spaces and remembering if you're vulnerable to severe disease, that treatment is a powerful tool. We're not using enough treatment. We know that Californians who do get infected with COVID and who are at high risk for severe disease, that getting early treatment can really not just save their life, but really save so much of the symptoms and difficulty of those initial days of infection. So we are amping up our messages. I'm doing some fun things in the next couple of weeks with influencers across our state to really amplify the message, and other colleagues both within the state and across the delivery system are doing the same. So trying to make it a fresh message, remind people that this isn't the time to let down your guard. And if you're thinking about doing it, no better time to do it in early December than trying to catch up in late December when we know the numbers are going to be higher than today.
And this seems like a particularly important time because people will be out and about around the holidays. And also in the next 3 months, as people hear about the COVID state of emergency in California ending on February 28th, to remind people that that doesn't mean that we don't take vaccines anymore or don't need them. So
we avoid the strain and difficulty on ourselves, our families, and the health system by doing our part. So I hope that's a message that we amplify more and more in days and weeks to come.
Yeah, I'm sure it will be. Another question from the audience: what can the state do to reduce the cost of medical care? Not through cost sharing, but by addressing the prices charged by medical providers. This is related to the earlier question about, that I asked about inflation and the cost of making healthcare affordable and people's concerns, which I've seen in surveys about the cost of healthcare. What can the state do?
I think there's so much the state can do and a lot that we're doing. But I will also say, government action in this space will only get stronger as public communities recognize more and more the impact of the high cost of care on their day-to-day lives, on their wages, on their other benefits, on their ability to do the things that they care about doing, and bringing that in the way we sort of communicate with our employers and our health systems, I think is an important thing all Californians can do. At the state level, I had the privilege through COVID, it was drawn out a little longer, to lead a Healthy California for All commission, where we looked at alternative strategies to deliver care, focused on how do we make it not just more affordable, but more equitable, more accessible, higher quality. And so we don't just want lower cost care, we want lower cost care that's actually better that's doing the high value things and not the low value things. And we have a long way to go to keep those channels of communication going. A couple of things, we're taking on drugs and the cost of drugs in California on our own. I appreciated the secretary's important points about what they're doing federally, but this governor on day one had actions focused on prescription drugs, and we're carrying that out, I hope, before the end of the year. We're talking about the execution of our partnership on creating the state's own brand of insulin. We're launching the Office of Healthcare Affordability that is really looking at different sectors of the healthcare delivery system and saying, we're going to expect you to hit a cost target and not have it go up very much every year, so that we can, over time, really make healthcare more affordable in systems, whether they're in the rural or the urban areas of California, treated a little differently. I think there's a number of things that we're doing on the regulatory side to make sure that whatever premiums we are paying, we're getting high quality. There's a lot of things within Covered California, our version of the nationwide exchange, that has been a leader, where really promoting higher value plans to people because of Inflation Reduction Act actions. So there's so many different things, but I believe, especially in the environment that we're in, that this is going to be a more important conversation on the heels of COVID, where people feel like maybe the healthcare delivery system did a lot for them in the acute moment, but could have done more in some other moments, and how costly it is, that we're going to really have an opportunity to have a smarter conversation here in the state, to not just do the things I mentioned, but build on them as well.
Thank you. So looking ahead, California will be expanding Medi-Cal coverage to cover all income eligible residents starting in 2024. And I would like to hear from you about how that is going to, how that's going to develop and unfold, and what your vision of how that's going to work will look like.
Well, just let me first say to the legislature, the governor, and thousands of people who for years, probably decades, have been trying to move towards this. Really, thank you and congratulations. We talk how Obamacare and the changes to Covered California and Medicaid expansion moved Californians' uninsurance rate from 17% to 7%. This move is going to bring it down probably below 4%. An incredible point. And for some of our most vulnerable low-income Californians, regardless of immigration status, to have that access is going to be key to our economy, to those families, to those individuals. So right now, we're busy at getting the youngest Californians, the oldest Californians who meet those eligibility in place, starting, this past May, over 50 now getting enrolled into Medicaid, working a lot with our communities to engage and inform folks that this is an opportunity. And then sort of this final swath, the 26 to 49-year-olds who come in, soon, but I'm sure for them, not soon enough. And in total, 1.3 million Californians potentially get covered when we're all said and done. And that's a tremendous success. So the work keeps on, but this is going to be, I think, transformative on a number of levels and for a number of communities that have long suffered health disparities and equities that we're seeing live and in color throughout COVID.
Thank you, Dr. Ghaly. So the governor was reelected, and we start a new term in January. And looking ahead, what will be your agency's top priorities for the next year? Maybe we've talked about them already, but I just want to make sure if there's anything that we've missed.
Yeah,
please
we didn't talk about one, and I'm surprised in a 30-minute conversation we haven't. You talked about it with the secretary, behavioral health.
Yeah, let's talk about it.
This is one sometimes I call myself and our team the chief dot connectors. Good. There's a lot of dots in behavioral health. There's a lot of transformation, CalAIM, state hospital transformation, changes to the Department of Managed Healthcare and their regulations, workforce, the crisis continuum, the 988 Mental Health Services Act, all of these pieces that are deeply connected, and yet there's gaps still. So working to create that comprehensive story, filling in the gaps, making sure that the vision we have for children today is one we extend to adults, where it's every kid in California, regardless of where you live, what your payer source is, that you should come to expect a focus on prevention, response, and stabilization in our system. That's going to take workforce, that's going to take buildings, that's going to take transform reimbursements, that's going to take higher expectations from all of us. And that is, I think, one of the key pieces, whether you're talking about mental illness or substance use disorders, whether it's about depression and schizophrenia, or it's about fentanyl and opiates. This is where we are spending a lot of energy. I'm proud of what we've done, but I see a long road ahead, and we're going to need every Californian to pitch in, because we all have our part on this.
Dr. Ghaly, I'm so glad we got to cover mental and behavioral health as well. So thank you for talking about that. I can't believe it, but we've reached the end of our program. The time went so fast. And Dr. Ghaly, Secretary Ghaly, I can't thank you enough for spending the time with us today and for your public service. I mean, you've done an extraordinary job in a very challenging time. We're fortunate to have you in the position where you've been in since 2019, and we really thank you for your service and for joining us today. I'd also like to thank our sponsors and for everyone else for joining us. And please be safe and have a good afternoon. Thank you.